So if I'm treating that patient and I don't have permission to extend the patient, I'm wondering if I could just lay her prone and do a couple extension moves and see what that does. Even if it's just grade 1, grade 2.
Yeah.
And then even get a lying prone and extension and see if that would change anything. But you couldn't do that yet, I know.
Yeah, that was my question, kind of, because like, how do you know when you can like really confirm you've ruled out the spine? Again, it's the balancing act of like the psychosocial, because she's afraid of it. But yeah, that was my thought. Like, what about just prone some extension moves, just kind of gently ease in, maybe, and just see what happens. I would just be nervous to rule out the spine if it's not really ruled out. So my question really for Jonathan and you guys is how would you know when you've ruled out the spine?
Mm-hmm.
So there's 2 ways in my eyes to rule out the spine. One is the flexum.
Mm-hmm.
And if you check repeated flexion sitting and they didn't change anything, you would still need to check repeated flexion lying, because you're moving from bottom up. And sitting, your semi-loaded position, you're moving from top down. So one could argue, oh, that's more aggressive. Yeah, it is. But it's still mechanically moving a little bit differently.
Mm-hmm.
So, if you test one thing and it doesn't change, you got to check the other one. Then you can really say, okay, I'm not going to worry about flexion. I can leave flexion and not come back, right? Then the other one to make sure you rule out lumbar spine is take it to end range extension. Because if there's symptoms going down to the feet and it's a lumbar derangement, then, or at least come from lumbar spine, then you should be able to elicit some sort of change, but you don't always get that change until you get to end range flexion or extension to sagittal plane. I wouldn't worry about lateral right now because it's bilateral symptoms.
Mm-hmm.
Yeah.
Okay, so maybe having moved her knees to chest and supine, because I'm moving bottom to top, which is a little bit different than the seated flexion.
Yeah.
Okay.
Then the other thing is when you're testing flexion, you got to monitor both things. It's chronic, so sometimes symptoms are hard to change, or it's hard for the patient to even sense change.
Yeah.
So you got to make sure you're at least keep an eye on.
Month after month, new guest experts sharing actual patient cases and subscribers sharing their own challenging and interesting cases like Elizabeth is in this one. Check out Case Conversations at mechanicalcareforum.com.